Okay, let's go live.
Good morning, everybody. Good morning. Now, I think, first of all, I would like to say thanks to the Professor Jerome Di and then Mr. Xavier Fellaria, and then Trancho. I think I'm sure of Trancho behind the Professor Jerome.
Yeah.
And thank you so much. And then also all the participants from the different area, different parts of the Myanmar who are working on ground for the revolution. And now, because we during the Christmas and we break and we make holiday. Stop the webinar. But now we are going to resume the every week webinar for the CME program, Continuing Medical Education Program for the Revolutionist, our Doctor for Revolution, and then a medical professional for revolution. Not only doctor, but also there's some nurses are also there joining the our webinar. And first of all, I'd like to say thanks to the today lecture, Mr. Xavier Fellaria. Actually, I think most of Myanmar doctors, they know him, and because he's been in Myanmar for many times before the coup, and then he working together with us, especially in the orthopedic hospital and orthopedic area, but also he involved in the medical, anesthesiology teaching in the Myanmar. That's why most of Myanmar anesthetists, they know him. And I would like to say thanks to the Xavier and for your commitment to Myanmar and also support to our revolution. And I know that you are going to give us support, medical educational anesthesiology training support. And not only that, he also support for the services. And thank you so much. Before you start, I would like to request the Professor Jerome, because he had a program for us for continuing medical education. And then I would like to request Professor Jerome to say hello to our audience, and then also please say some program for the future. Thank you. Thank you very much. Jerome, please.
Yeah. Yes, thank you, Zo. So it's a pleasure for me that we can continue this medical program. I think is very important for you, and that means that we continue to support you and to improve your knowledge in medical things. And so we will continue with that, and also we start a program for other topic like chemistry, like mathematics, and other scientific things with Paul Sabatier University. It's a university very famous in France, in Toulouse, and this program will start also this month. So I'm very proud of that, to continue to improve the knowledge of the Myanmar people. Is very important. And secondly, I would like to say thank you very much to Xavier. He joined us to teach in this medical program, and Xavier, you told that he's very famous in Myanmar. He helped a lot, and I am very happy that he can continue to help us. So thank you, Xavier, and thank you, Zo, to continue for this medical program. So I think now we can start with Xavier.
Thank you.
Thank you so much. So may we start, may I share the presentation?
Yes.
Yes. So welcome, everybody. So we are going to speak today about major problem we can have in anesthesia is difficult airway and how to manage difficult airway. When you can't breathe, nothing else matters. So yeah, it can be very challenging. It's very well-known take here from someone still awake and needing a tube. So what is the difficult airway? It's difficult to ventilate. It's the sign of an inadequate ventilation, which could not be reversed by mask ventilation, or oxygen saturation could not be maintained above 90%, or the difficult to intubate. If a trained anesthesiologist using conventional laryngoscope, which is not anymore now with all the video laryngoscope that we have, takes more than 3 attempts or more than 10 minutes to get a tube. So if we look at the prevalence, it's very difficult to know. If we use a proper evaluation, it will only be validated between 15 and 50%. It means difficult airway is not easy to be evaluated. While the difficult face mask ventilation in general is about 1 out of 10,000, only 15% of this one will be a difficult intubation. And the average of difficult intubation, these are the last published data from UK, every 22,000 anesthesia, it will happen. And the mortality rate is 1 out of 120,000. It means if we see in a hospital performing perhaps intubated 10,000 a year, it means perhaps it will happen one time in the 11 years. The last one there was a very long time ago for us. Although difficult or fail intubation occurs infrequently, the can't intubate, can't ventilate situation, it's 25% of fatal events in anesthesia. So, safe airway management, it means evaluation. It means identification of the difficult airway. It means assessment of other clinical factors, the plans we need to make, and reasonable alternative plans. So I won't speak here of the very, very sophisticated things we have, because it's not the situation in Myanmar. So we are going to try to stay very practical. So it's very important to have a plan depending on what you have for tools. You need to develop a plan and a backup plan. And also you need guidelines, and this presentation, I will send it, it contains all the last guidelines and flowcharts about intubation. So the 3 pillars of airway management: patency, airflow integrity, protection against aspiration, and the assurance of oxygenation and ventilation. So when can we discuss the causes of difficult intubation, the basic airway evaluation, the plans, the tools, the unexpected difficult airway, and then we will see the American Society and the Difficult Airway Society algorithm. So at the side of the doctor, why can we have can it go wrong? So we have inadequate preoperative assessment. I think in your situation, you don't have any assessment. And in our side, since COVID, we are evaluating our patient on the phone, so we don't see the patient. We don't seem to have more problem because we haven't seen the patient live. Inadequate equipment is a little bit the situation in Myanmar now. Not experienced doctors, it's also the problem. You have poor technique, so if you can't train, you can't get the technique. malfunctioning of equipment, it's also a major problem, and inexperienced assistance. If I have a look now in this dramatic situation in Myanmar, and say, okay, we have a lot of factors doing that, it can lead to difficult intubation. And then patient, yeah, we have the congenital causes and the acquired causes. So shortly, we have patient with a short-necked, protruding incisor teeth, long high-arch palate, poor mobility of the neck, and then the increase in either anterior depth or posterior depth of the mandible and decrease in atlanto-occipital distance. This we are going to see in some pics. So patency, relief of obstruction, protection from aspiration is very important. Hypoxic, hypercapnic respiration failure, airway access for pulmonary toilet, drug delivery, therapeutic hyperventilation, and shock. These are the indications for active airway intervention. So the signs of airway, of compromised airway: inspiratory stridor, snoring, gurgling, drooling, hoarseness, and paradoxal chest or movements and tracheal text. All those signs means you have a big problem. So protection also, it mainly you have a lot of trauma, so blood in the upper airway, pus in the upper airway, persistent vomiting. It's a major problem we have every day at the OT in emergency situation, and the loss of protective airway reflexes when you give anesthesia, for instance. You have to look at your patient, to observe your patient, central cyanosis, obtundation and diaphoresis, rapid shallow respirations, accessory muscle use, it's very important, retractions, and abdominal paradox. So also in the basic airway, you have to ask the patient if you have some assessment, previous anesthetic problems. The patient can say, yeah, last time I had a difficult intubation. I have a card with me, of it has been taught to me that I was a difficult intubation. The general appearance of the neck, the face, the maxilla, and the mandible can show you or let you think about it's going to be difficult. Jaw movements, head extension of movements, the teeth, oropharynx, the soft tissues, and if you have recent chest and cervical spinal rays, X-rays, it can help. So we are going to take it very simple, easy look, evaluate, do a melanopathy, is there any obstruction, and observe the neck mobility. So externally, you have an obese patient or very small patient with a beard. A beard can be very, very challenging. Short muscular neck, large breast, prominent upper incisors, receding jaw. The retinoscopy is very also known as a big problem. Burns, facial trauma, stridor, and macroglossia being a tongue. It's very important to evaluate the 3-3-2 rules. 3 fingers fit in the mouth, 3 fingers fit from mentum to the iris cartilage, and 2 fingers fit from the floor of the mouth to the top of the thyroid cartilage. And the melanopathy, it's very important to evaluate the melanopathy score, varying from class 1 to class 4. And when you will intubate your patient, you will observe the Cormack score, going also from 1 to 4. And I have very short film from 1 minute.
The Mallampati classification relates tongue size to pharyngeal size. This test is performed with the patient in the sitting position, the head held in a neutral position, the mouth wide open, and the tongue protruding to the maximum. The subsequent classification is assigned based upon the pharyngeal structures that are visible. Class 1, visualization of the soft palate, fauces, uvula, anterior and posterior pillars. Class 2, visualization of the soft palate, fauces, and uvula. Class 3, visualization of the soft palate and the base of the uvula. Class 4, soft palate is not visible at all. A Mallampati Class 1 view suggests ease of intubation and correlates with a Cormack and Lehane laryngoscopic view grade 1, equal 99 to 100% of the time. A Mallampati Class 4 view suggests a poor laryngoscopic view, a Cormack and Lehane grade 3 or 4, equal 100% of the time. Beware of the intermediate classes, which may result in all degrees of difficulty in laryngoscopic visualization.
So what is the validity of the test? We see sometimes patient with a Mallampati class 1, who's going to be difficult to intubate. So the validity of the test is not really good, certainly with the Mallampati 4. So we need to do it, but it's not always valid. So it has to be combined with other tests. As I told you, the 3-3-2 and observe the patient. Obstruction. It can be blood, vomitus, teeth, epiglottis, dentures, tumors, or impaired objects. So the neck mobility is very important. I said just now, please observe your patient and ask for the neck mobility. Perimental distance is a very, very important factor you need to measure if you have some doubts about it. You measure from the upper edge of the thyroid cartilage to the chin with the head fully extended. When it's short, it equates with an anterior larynx, and it's greater than 7 centimeters, it is usually a sign of an easy intubation. Less than 6 centimeters is an indicator of a difficult airway. It has to be combined. It's not with, okay, less than 6 centimeters is going to be difficult. It has to be combined with a Mallampati and observation of the patient. And then you need to intubate your patient. And once again, a short video to let you see how to perform intubation.
Ensuring that the patient's head is in the sniffing position, the laryngoscope should be gently introduced through the open mouth. Check that the lower lip is not caught between the teeth and the blade. The laryngoscope blade should be aimed towards the right-hand corner of the mouth. It may be necessary to use a right-handed laryngoscope, whether a bad or capped teeth. The blade is placed against the tongue and advanced along its curve. Staying in the midline is very important. A visual reference to the uvula periodically will confirm the midline position. The blade is advanced along the tongue towards the epiglottis, which will be seen in the anterior structures of the neck as the patient is lying down. The tip of the blade is advanced to the base of the epiglottis. Now lifting the whole laryngoscope in the direction away from the front teeth, but such that the epiglottis can be lifted up towards the ceiling, the epiglottis lifts up and almost curls up against the laryngoscope blade tip. Then right behind the epiglottis, the vocal cords can be seen as two straight, thin, white bands around the entrance of a hole, which is the opening of the trachea. The vocal cords are closer together anterior and diverge, so they're further apart posterior. If you are intubating in a patient who is breathing spontaneously, you will notice that the cords move with respiration. They move apart, that is, the aperture becoming bigger on inspiration and closer together on expiration, making the aperture smaller. Often, a beginner will not keep the blade in close contact with the tongue when sliding the blade in, and the blade will go past the epiglottis. Then the operator has no idea of what he's looking at. It's important to realize the blade can be advanced too far beyond the epiglottis. When this does happen, the blade must be pulled more effectively up against the tongue and then withdrawn slowly until the epiglottis comes into view. Then the tip of the blade is placed up against the base of the epiglottis. When the vocal cords or part of them are visualized, the endotracheal tube of choice is passed through them. Space is limited in the mouth and pharynx, and the endotracheal tube takes up most of the space. The tube is curved and should be introduced at the corner of the mouth. This keeps the tube and the operator's hand out of the operator's line of sight. The tip of the tube can therefore be visualized until it passes through the vocal cords.
Okay, how to manage anticipated difficult airway. So when you know that you are going to be confronted with a difficult airway, please don't stay alone. You have to discuss with colleagues before you check the equipment you have. If you're junior, please try to have a senior to help you. And you need a plan A and plan B and perhaps then plan B, C, D, and we have 26 letters in our alphabet. Ideal situation, surgery team standby when you know you're going to be confronted with a real difficult intubation for an emergency tracheostoma of cricoidectomy. So please pre-oxygen the patient. It's very, very important to give a lot of oxygen to a patient. It will allow you much more time when you have a difficult intubation. And succinylcholine itself, it won't save your account. You need to pre-oxygenate your patient. How much is enough? So, tidal volume breathing for oxygen for 3 to 5 minutes, or the deep breath techniques we are using mostly is shorter, 4 times within 30 seconds. Both are effective in increasing the PaO2. And successful intubation, you need to bag the patient. You maximize neck flexion, you move the tongue out of the line of sight, maximize the mouth opening, you look for landmarks and adjust the blade. The burp maneuver, increase the lifting force, consider perhaps a Miller blade, and bag the patient again. And how to bag the patient.
Proper patient positioning is essential. Align the ear canal at the level of the sternal notch. Morbidly obese patients may require several feet of elevation. Always use an oral or nasal airway in an unresponsive patient who is being ventilated. Place the top of the mask at the bridge of the nose. Lower the bottom portion of the mask, covering the mouth and nose. Avoid downward pressure on the mandible. A single provider should use the E-C grip. The C is created by the thumb and index finger around the mask. The E is created by placing the middle finger under the mentum and the ring and little fingers along the angle of the mandible. Provide jaw thrust with the E. If possible, use 2 providers with a 2-handed technique over the mask. Use the thenar eminences to provide a mask seal, while the index to little fingers provide jaw lift along the mandible.
So, what do you need to consider? Merits of feasibility, awake intubation or intubation after induction of GA, non-invasive technique for initial approach or directly invasive technique, and preservation of spontaneous or ablation of spontaneous ventilation. And sometimes I would say when you know it's going to to be very difficult, please don't intubate your patient. You can give very good GA only with ketamine, high doses, and the patient will keep on breathing, and you can do a lot of surgery under only ketamine. So if you don't get the tube, what are you going to do? Plans A, B, C, and how to answer before you tube the patient. So there is alternative. You need different length of blade, different type of blades, and different position. Plan B, bag your patient, and as we have seen on the film, consider 2% mass ventilation. The combi tube, it's very easy to use, and I brought some to Myanmar some years ago. It can be a very good option when you have a big problem. And the LMA, the lungs masker, is also a wonderful option. So then plan C, the cracked needle or surgical tracheostomy. So failure, what does it happen? Why do we fail intubate? Mostly no critical discussion with colleagues. You go alone. You didn't request on time for experienced help, or exaggerated idea of your personal ability that we see a lot. Ill-conceived plan A of plan B, poorly executed plans, and persisting with the plan A too long. It's the very, very beautiful, wonderful example of some years ago in UK from the pilot's wife who died after a very difficult intubation. And it shows us that the anesthetists, they stay with plan A many, many minutes, whether this saturating patient will die after. It was the beginning of the crew resource management for anesthesia. Not involving and preparing surgical colleagues. It's also very important to have a team when you know it's going to be difficult. So the tools, we have the rigid laryngoscope blades, and we have the so many different blades. We have now the video laryngoscope, CMake or others. We have different tracheal tubes, guides, stellates, ventilating tubes, the lighting tubes. We have the LMAs, we have the fiber optic, the retrograde intubation, the non-invasive airway, and the emergency invasive airway with needle and surgical cracopherectomy, and when you have it, an exhaled CO2 detector. So we have the McGill, the Miller, the polio blade. Mostly we use the McGill, and in children we use the Miller and the Macintosh, sorry, and the Miller. When you have two types of blade, it can help you. The bullet, we have one colleague still using it. It seems to be very, very interesting in difficult airway. It's a reusable kit, but yeah, it's almost not seen anymore. The bougie is very, very useful to have many bougies. You can wash them again, reuse them again a long time. The combi tubes are very important because you place the tube whenever it's in the esophagus or in the trachea, it's always good. And the LMAs and the intubating LMAs are good options. So the esophageal tracheal combi tube is very useful in emergency situation. It's a double lumen tube. When you place it somewhere, it's always good. If you are just in esophageal, you have a balloon which minimizes the aspiration. Where you are lucky in the trachea, you will ventilate your patient. So the combi tube is a good option. The LMAs, I would say, please go back to the reusable LMAs. The iGels, it's only for one time. If you wash them 2, 3, 4 times, they become some porous and you can't use them again. So it's very interesting to have the old-fashioned LMAs. So the LMA insertion, I have it here. No, sorry, my link doesn't work. So I will put it again. So we have different LMAs. The classic one, you need the classic one, the flexible ones, the unique one, iGel once again, and certainly in children, the iGel not the best solution. The fast track and the ProSeal. The ProSeal, you can do a lot of surgery, also abdominal surgery with the ProSeal larynx mask, LMA. And the fast track, I know I brought a lot in Myanmar some years ago. It can be very, very useful when you have a difficult intubation to intubate your patient using an intubating LMA. You insert the laryngeal mask and then you hope that you will intubate your patient through the LMA. The ProSeal, it's the most advantageous LMA that you can have. And we will have a look with what some companies, if I can get some to be brought to Myanmar. With those ones, you can do some short laparoscopic surgery, you can do abdominal surgery. It's mostly safe and you can ventilate your patient. Fiber optic, I would say, okay, when you have it, when you're trained, it can be very useful. And the retrograde intubation is something you may use when you have a big problem, but it's only the problem, what will you use to perform it? Also, you have first to advance an 18 of 16 gauge through the trachea, and then you need a wire guide. So which one are you going to take? The problem, I take myself for the very long central venous lines. And then you will advance the TFE catheter and then the tube on it. When you have a big problem, you can also make a bigger hole and advance a bougie in it, and then you can put your tube on it. But the most important is the unexpected difficult airway. So perhaps you won't have help within 1 minute. The equipment is not ready. General anesthetic has been given. You have long-acting relaxants, and backup airway management plans may be poorly thought out in the emergency situation. So not able to ventilate and not able to intubate, or both. So as said before, 2% mass ventilation can be useful. You can use supraglottic airways, combi tube, LMA, and subglottic invasive airways, invasive airway access, and transtracheal jet ventilation. But it's you don't have jet ventilation, I think. So don't we. Technique for difficult intubation, optimal external laryngeal manipulation, alternative blades, intubating stellate, laryngeal mask airway as intubating conduct, as I said with the intubating LMA, light wound. It's something which has been very successful some years ago. Alternative technique of intubation. Then when you're on time, awake, blind, fiber optic, retrograde, or invasive. These are all the tools we can use in case of unexpected difficult intubation. So manipulation of the airway and different blades of bougie, that's the first step when you can't intubate your patient, then you give a LMA of intubating LMA or a combi tube. Then the retrograde intubation can be a solution, and then you have to go to the surgical phase. Surgical airway tracheostoma of the cricothyroidotomy, it can save the life of the patient. So you need to be familiar with the kit. Please try to follow something on YouTube if you have never used these kits. Use setting technique of knife cutting and direct connection with the ventilator. So I'm going to show you something which could be very, very useful in emergency airway. An orthodox method. It's not accepted, but when you don't have anything else, it's very important that you know that you can connect the tube of the catheter to the ventilator via a 3 millimeter tube. You connect the tube to a 5 millimeter syringe, and you can insert a tube 7 and inflate the cuff, and then connect the ventilator. So and connect the tube to the cath with a 3 milliliter syringe, and then you can adapt the adaptator of a 7.5 tube. It's better to see the pics. So you have the adaptator of the endotracheal tube 7.5. You have a 3 milliliter syringe and a 16 gauge catheter, or you have here with a tube 3 adaptator, you can direct connect to the 16 gauge catheter. That is very important because it's when you have nothing else, it can save a life. Like this. And you can connect to a traditional ventilator, but you need a high pressure. So it's better a self-inflated reservoir bag to ventilate the patient. So which ones? Very difficult, I would say, in the situation, the actual situation in Myanmar, you need ProSeal, combi tube, and perhaps intubating LMAs. So I am not going now to details all the guidelines, because in this presentation you will have it, and you can use and read them. These are the difficult airway, difficult intubation guidelines, or the overview, and it will remind you the plan A, B, C, and D. We spoke about it now. It's very important to learn all those plans because it's not when you will be confronted with a huge problem that you have to go back to a presentation or to a paper, and perhaps it could be interesting to have a print at your OT to know what you need to do when you have a big problem. So, and this is also the management of the unanticipated difficult tracheal intubation in patient. It will indicate you what you need to do in case of a big problem. Then at the plan D for the surgical intervention. Then the extubation is very important also to know how you're going to extubate your patient at the end of the surgery. And the extubation is also a very important moment. It can be very risky. So you have also to plan the extubation of your patient. You need to assess airway and what are the general risk factors. It has been a difficult intubation. This has been a difficult patient. You have saturation problem during the intervention. obese patient, OSA patient, respiration risk. These are the airway high risk factors, and the general risk factors: cardiovascular, respiratory, neurological, metabolic, the special surgical requirements, and the special medical conditions. This you have to know it. So the plan, and then you have to prepare for extubation. So perhaps you have to optimize some patient factors before you extubate: cardiovascular, respiratory, metabolic, temperature, neuromuscular. It means sometimes you have to wait before extubating your patient. It's better to wait some longer than to have the risk of needing to intubate again and in some risky conditions. And also sometimes you need to optimize other factors. And sometimes you need some assistance. So you have to stratify the risk. Low risk is fasted patient, uncomplicated airway, no general risk factors. And then you have the at-risk patient. You have some doubts about the ability to oxygenate if you get the patient extubated. Reintubation can be very difficult. It's been difficult before. Or the general risk factors are present, and you have to give again anesthesia, and it can be very dangerous for the patient. So then you perform the extubation. You follow a low-risk algorithm or at-risk algorithm. Then you will decide what you're going to do with your patient, to put him to the recovery or to an ICU if you have one. But please do a safe transfer, and if needed, give O2 oxygen to your patient and observe minimally with a saturation. Then these ones, I won't give you all the details because you will read it by yourself, and perhaps it could be another lecture about the intubation in children. These are some guidelines about the difficult mass ventilation during routine induction of anesthesia in children from 8 to 8 years. These are what you need to do. Then the unanticipated difficult tracheal intubation in children, what you need to do. And these are also very important factors. You could be confronted to general anesthesia in obstetric, and obstetric, we know, giving general anesthesia in pregnant women can be very, very challenging. Also for us in our modern operating theaters, so in some dramatic poor situation, it can be very, very challenging. So I would say intubation in obstetric patient, it can lead to failed tracheal intubation. So you have to plan and to prepare. You have to use a rapid sequence induction. You have to consider face-make ventilation, and about laryngoscopy, it's maximum 2 intubation attempts. The third intubation attempts only by experienced colleague. Success. You plan your extubation. If it's failed, you declare the failed, you call for help, you maintain oxygenation, and you give an LMA. Laryngeal massacre is very important. Can't intubate, can't oxygenate, so then you have to go to the surgical cricothyrotomy. It's very important to save life, and once again, in pregnant women, it can be very, very challenging. This is the algorithm about safe obstetric general anesthesia. it will give you all the steps you have to follow. And once again, when you are not experienced, you try 2 times, and the 3rd time if you're alone, you give an element, that's it. And if you have a senior, you call the senior. And when it fails, it's dramatic. You really have to know what you need to do when you have a failed intubation obstetric patient. This is the 3rd step. And these are all what you have to consider when processing surgery in pregnant women. So this, I won't give you all the details. I won't read everything. Once again, I will send this presentation and you will have it and you can read it. And when you need all this on paper, it's very easy just to contact me, and I send you all what you need. And this is the version of the difficult airway from the American Society Anesthesia, which is the best easy one, telling you what you have to do when you are confronted to a difficult airway. So once again, difficult airway, it's preferable to use super adjustment to avoid having to use super skill. And there are usually a bloody mess, but a bloody surgical airway is better than an arrested patient with a nice looking neck. So it means it can be a very bloody situation, but if you save the life of your patient, it's the most important. So once again, there are some very challenging situations. Thank you.
Okay, thank you.
Thank you so much. Thank you.
Question.
Thank you.
Okay. So for this presentation,